Welcome. Come with me. The doctors will see you now.
All right, welcome back to another episode of Fast Talks with Family Docs. I am Dr. Phil Palmer.
And I'm Dr. Veerbadala. We're sitting here with Dr. Kouandjio talking about all things ER from the perspective of a family doc. Dr. Kouandjio, thanks again for being here, sir. I had another question because I was curious. As a family doc, is credentialing any different for the ER?
Not really.
Okay.
Not really. So we get credentialed just like everybody else gets credentialed. Obviously, I think the only difference in credentialing and getting a job in the ER as a family medicine trained physician is really where you can work, and not really a difference in credentialing. So. The bylaws, a lot of hospital bylaws, especially the level 1 trauma centers, usually, and I'm going to use that word usually because I've seen some family medicine trained physician work in trauma 1 level.
Oh, wow.
Level 1 trauma centers. But usually level 1 trauma center will rather have board-certified EM-trained physicians rather than family medicine physician. But with that being said, who wants to work in a level 1 trauma center? I don't know about that. I don't know if I want to work in a level 1 trauma center. But level 2 and up are usually fair game, like 2, 3, and 4. And I guess the ones that are not placed in a bracket are all fair game, but 2, maybe so, but 3 and 4 usually they're
good to go.
Yeah, they're really good. Most of the time they're good to go.
Yeah, and it seemed to me like back in, I don't know if it was back in the 90s when there was more of a shift, and some of the hospitals were trying to change their designation as to what they were. I think some systems wanted to, as a marketing tool, we have board-certified emergency medicine doctors working here.
Yes,
and so it wasn't necessarily a requirement of anybody ever. It just got created as a requirement for something they wanted to represent. Because I have a vague recollection earlier in my career of some turmoil from other primary care docs that had been working in the ERs regularly, moonlighting or some other things like that then couldn't do that in the urban areas anymore around
so
the
they had to
metro
leave
and
the
had
job.
to start going a little further out to do the moonlighting or do something different. So, and again, I'm old; my memory may be poor, but I think things related to that.
I think you have a point.
Dr. Kouandjio, I'm curious what your advice would be is if there are family medicine residents listening to our podcast that have an interest in doing ER work.
Yeah.
What should they do to prepare themselves? And let's say they don't necessarily want to go the fellowship route and be in an urban area, but they're intending to go back rural and they know they'll have obligations of covering the ER because of where they work. What would you suggest that they consider as a part of preparing themselves to be in that environment and have that role in their future practice?
Yeah, absolutely. So the first thing they need to do is do that research, right? Just research. Is this the type of, is this really what you're interested in? Do you really want to do this? Do you think the lifestyle of an emergency room physician would agree with what you want your life to be like? The nights, the weekends, the holidays and stuff like that. So research. But next to that, I will tell them to do what I did. So if you work in a hospital, go into the ER, let the attendings in the ER know that, hey, you are for real. You really want to do this. Because a lot of people, see, emergency medicine is acquired taste. Yeah. A lot of people do not want to be in the ER. They just hate the ER.
Yeah.
It's very acquired taste. So when different specialties go into the ER for rotation during residency, a lot of times the attendings are like, oh, he or she are just here because they're required
It's
to be here.
requirement.
Yeah, they don't really want to be here. So the first thing you do when you get in there is let them know that, hey, I really want to do this. I'm really interested. So please treat me like everybody else if there's a residency program there. If not, just let them know that you're really interested so you can so they can teach you how to operate as an ER doctor, okay? Because a lot of us know the medicine, we know the clinical stuff, but knowing the clinical stuff and actually operating as an ER doctor are two different things, and that's where a lot of people actually struggle, okay? So you go in there, you let them know that that's what you want to do. They take you under their wings and they teach you and you get you comfortable. And also, obviously, if you do not want to do a fellowship, which I don't know why anybody wouldn't want to do a fellowship, but obviously you need to educate yourself, and there are a lot of resources out there to educate you for education out there, like on the internet and stuff like that. So education, big presence in the ER, and just knowing that's exactly what you want to do, like if you really want to do it.
Yeah.
Those are the three advices that I would give them.
So I'm curious. In the 90s when I was starting, when I was a resident and then early into practice, there were a lot of residents, family medicine residents, that would moonlight in their second and third year and go out to smaller towns across Oklahoma and moonlight and cover their ERs over the weekend.
Yeah.
My experience has been they don't do that, and I don't think they're prevented from doing it. I think there's just so many urgent cares in the metro area now that they can get a similar reimbursement and not have to drive as far and deal with the ER type patients. So I see them doing more urgent care now. But I'm curious, at your residency, did you moonlight? And if you did moonlighting, were you able to moonlight in the ER? Was that part of what you did to prepare yourself, or not really?
Unfortunately, my residency did not allow us to moonlight. So I had zero moonlighting experience. But had I had the chance to do it, that would have definitely been an option for me. I definitely would have did it. But and that's actually one of the advice that I would give some of the residents. Like, if you can,
go ahead and do it.
Go ahead and do it. However, again, do some homework about the facility you're going to moonlight. Okay, because they will say, "Oh, it's a rural facility, it's low volume," and then you go there, you see high acuity, high volume. So you have to make sure that you know exactly where you're going before you go there. Because a lot of these facilities, in those rural facilities, they want people to go there and moonlight because they're struggling. So a lot of times, they won't give you the real info about the location, and then when you go there, it's chest tubes and intubations and this. So
ask a senior who's done it before. You know.
So I've worked I moonlighted here in Oklahoma in some rural areas, but I'm telling you, it's
different.
It's you need to. It's not just go there and chill. Right? You need to know your medicine. You need to know some of those procedures because it's the ER. You must see them.
That's right. Yeah. You might. And I know you made a comment a little bit earlier about how you need to understand the ER approach. And having had the opportunity to do some medical executive committee, more administrative engagement with a hospital, that you're right. Because, we see someone with chest pain and we think about, well, I need to get an EKG and do I need to call EMSA? What's going on here? But in the ER, you've got a clock ticking that when they walk in with chest pain, you've got to have an EKG documented with a certain time, and cath lab clock is going if they're going that direction. and TPA and different things you're doing with strokes. That there's things that we deal with as family medicine docs, but not in that time-sensitive environment. And even for things that aren't critical, like MIs and strokes, I know there's I think throughput time is the term of when someone comes into the ER, there should be a decision and them either released home or admitted to the hospital within a certain time frame. And yeah, we have a time frame for in the clinic, but we're not necessarily seeing as many patients at once with as many mixes of complexities at the same time as an ER doc may be dealing with. And so I think that is true, that mentality of it's more than just the medicine. There's some administrative burdens, expectations is probably a better term, burdens that ER docs have to deal with in that environment.
Yeah, it's a different environment. And also I look at the ERs as team sport. I think it's a team sport. You're working with, nurses, techs, et cetera, et cetera, et cetera, et cetera. So they also expect you to play the same sport as they're playing, right? You cannot go to a basketball court and start playing football with people who are playing. So that's not going to work. So people expect you to function a certain way, and you have to. Otherwise, it breaks the flow of the ER, and it can cause some serious issues there. But
that's true.
Can't use your hands in soccer. That was my attempt at a sports reference. A very interesting show I've been watching is called The Pit. Have you seen that before?
I've watched a couple of episodes.
What are your thoughts? Does it really replicate the ER?
I think it's the closest show to real life.
Oh, awesome.
Yeah. It's closest to real life than any other medical show that I've seen so far.
Yeah. What's captivating is it seems like these are like real life stories, and we just see the struggle, and not just clinical, but the admin burden that Dr. Palmer was talking to you about. But do you have any stories like that just resonated with you and that stuck with you still now that you'd like to share?
As far as what, can you?
Like your experience in the ER, maybe even bringing up what your training in family medicine was kind of shined and
we need the weird patient story.
So many stories, but so many stories. But again, I don't really have one that I can pinpoint. But I will tell you this: I think I have a better way I think I interact with my patients a little differently.
Sure.
And as a result, I feel like my patient open up a little bit more to me than they would other docs. Yeah. So that's really one way that I can say that my family medicine residency or training has an impact on my ER job. Is really, again, the way I interact with my patients, and also the way I look at the long-term care of my patient. What happened beyond disposition? What happened when they go home? Do they have any issues at home? What are their social barriers at home, the social obstacles? So it's a lot of nuances, a little things like that a lot of ER doctors just don't care too much about, because it's just but as a family medicine trained ER doc, I kind of, in the back of my mind, I think about those things. I think about the long-term care. I think about what's going to happen when they get home. When I feel like they might be holding some information back, I kind of tap into that family medicine training to try to get a little bit more information from them to help them. So I'm sorry to disappoint.
No,
really.
Great.
I don't really have a specific example, but I tap into my family medicine training on a daily basis. in the ER.
And when you say they open up to you, I think it's really important to have that comforting presence in the ER.
Yeah.
Being able to calm people down.
Yeah. Well, I want to take us out of the ER.
Okay.
Dr. Vidala had mentioned during the intro of our last episode that you do content creation to take complex medical info and make it more accessible to the public. So I'm curious, if I understood that correctly, what exactly are you trying to do? What platforms are you using to get that content out to the public? And what got you interested in doing that?
All right. Thank you for asking me about that. So I'm going to tell you what made me do it. Okay. So we all work in this state, which is, we all know the stats, our education stats and our healthcare stats. Right. Okay. I don't need to tell us where we rank here. I'm just going to leave it alone. But when you work in a high volume environment like the ER, where you see people going in and out, and you have to educate them.
Right.
Yeah, you have to educate them, and then you realize that, wow, I'm doing this one person at a time. How can I scale this? How can I educate more people rather than one person at a time? So that's where the idea came from. Now, I'm going to try to tell this story without breaking any HIPAA laws here, but I did have a patient who came into the ER with a amputated finger. Okay. The wife had it in milk. Yeah. So I asked the wife, hey, why milk? Yeah. And she gave me, that's what I always thought. I grew up thinking, put everything in milk. So that was really the catalyst that made me say, okay, I'm going to go home and I'm going to get a camera and then I'm going to get a microphone and then So that was really the catalyst. So the catalyst for me, the idea behind it was just educating the public, especially coming from a state like ours. Right. But it's been really fun. It's been amazing. I've been doing it for about, 7 months now. I think I started in May. Yeah. Okay. I started in May.
So it's a podcast that you're doing?
A podcast. Okay. I'm on YouTube, Facebook, Instagram, all the major platforms. Yeah. It's been growing very well. Good. My goal when I started this podcast, for example, my goal was to get 1,000 followers per platform in 1 year.
Okay.
So right now on YouTube, after 7 months, I'm at, I think, 12,000 followers. Yeah.
That's awesome.
So,
fantastic.
Yeah. From 1,000 followers in 1 year to 12,000 in 7 months, I'm very, very, very happy.
Oh, that's amazing.
Getting a lot of feedback, and I feel like I'm getting a lot of people are actually learning, I think, because I'm getting a lot of messages. I'm getting a lot of thank yous. Hey, I didn't know that. Oh, I'm going to do this a little differently this time. So it's been super, super, super rewarding. And I actually feel like I'm doing something that the public is actually benefiting from. So,
That's amazing, sir. What's the podcast called?
It's super boring. Okay. I go in there. I go by Dr. Kouandjio, your hero.
Oh, okay.
And that's pretty much, if you look me up anywhere, Dr. Kouandjio, your hero, you'll find me.
That's your Instagram
that's my
handle
Instagram, Facebook, YouTube, and X. I'm on X also.
Okay.
Excellent.
Awesome.
Excellent. Well, I'm grateful you took the time to sit down and visit with us. I've surely enjoyed learning more about you and your practice and your experience in emergency medicine. So thank you for being a part of our podcast.
Well, thank you so much for having me. It was a lot of fun.
Pleasure, sir. A lot of fun.
So listeners and viewers, that's all. But we'll see you next time on another episode of Fast Talks with Family Docs.
Thank you for joining us today. The doctors would like to see you back for another check-in. Please choose to follow our podcast, and you will automatically be notified when it's time for your next appointment.